Good morning, everyone. So I'm going to present a series of spasm of near reflex cases which presented in the post-COVID era. We are also presenting a diagnosis and a management protocol. As we all know, the near reflex consists of accommodation, which brings the near point to focus on the retina by the contraction of ciliary muscles and increase in the convexity of the lens. It also includes convergence, which again brings both the visual axis to converge on the point of target. So spasm of near reflex is basically an excess of spasm, excess of accommodation, which results in pseudomyopia, which results in blurred vision, causing asthenopic symptoms, and a spasm of convergence, which can result in variable esotropia, presenting with double vision and furthering the asthenopic symptoms that the patient has. So previously, if you look at literature, spasm of near reflex was described as a rare entity with an incidence of about 5.1%, and there was no fixed protocol for the management. But in the post-COVID era, we saw that the number of spasm of near reflex cases was on the surge, and we saw a significant rise. So we decided to study these patients in the period of July 2020 to 2023. About 30 patients were recruited. Detailed history was obtained, including a history of total screen time, total near activities, and psychological history to look for any stress factors. A detailed ophthalmic and orthoptic evaluation was done. Particularly, we paid attention to the accommodative parameters like negative relative accommodation, positive relative accommodation, dynamic retinoscopy, and the accommodative facility. Again, convergence parameters were assessed using cover tests and looking for the positive and negative fusional vergence. So a diagnosis of spasm of near reflex was then established using these parameters, and then treatment was initiated with cycloplegics, with hyperopic correction or refractive error correction, and orthoptic exercises. We reviewed the patients every 1 to 2 weeks, and all the accommodative parameters especially were assessed in every visit. Treatment was then tapered or escalated depending on what we found. So if you look at the results, 53% were males, about 47% were females. And if you look at the age parameter, the average was 17 years, but the youngest was just 6-year-old, and the oldest we saw was even 35 years old. So what we saw was that the near work time was on an average high in all the patients with an average of 8.79. 7 had stress factors of exams, and 7 had some psychological stress factors. These patients were sent to psychological counseling. 1 patient was already on treatment for depression with a psychiatrist. So if you look at the total screen time, it was anywhere starting from 5 hours to even extending up to 12 hours. This was a total near work time, but if you look at the total screen time was also high in almost all of these individuals. The cycloplegic refraction varied from 9.5 diopter to plus 3.5 diopter, and the refractive error distribution was as follows. We saw that most of these individuals were myopic, 43%, 40% were hypermetropic, more than plus 0.5, and emetropia, we included patients with less than 0.5 diopter refractive error. And orthoptic parameters were as follows. We saw that the NPC was of course close. This was assessed only in the accommodative component patients. The near point of accommodation was of course close, especially except for the patients who were older. The negative relative accommodation was low, that is the ability to relax was low, the ability to stimulate was of course high. It was even as high as 13 diopter. And with accommodative facility, we saw that these patients found it difficult to relax the accommodation with the plus flippers. So we classified the cases as those having dominant accommodative component, which were 11 in number, a total of 36.6%. Dominant convergence component was seen in about 16.6%. Both accommodative and convergence component were seen in about 14 patients, which is about 46.6%. So this is a case example of a patient with both accommodative as well as convergence component, a 15-year-old male who presented to us with acute deviation of the eye. And what we saw was the NPA was very much close, and the amplitude of accommodation was high. The PRA was high. And on dynamic retinoscopy, we saw that there was an accommodative excess. And of course, in the facility, it was low because the patient could not relax the accommodation. So this is how we went about with the management. So we first started with hometropine 2%, but then we saw even with that, the positive relative accommodation was actually high. So you can see the PRA was still 11 diopters. So therefore, we shifted to atropine 1% twice daily. And then you can see that there is resolution and the PRA then reduced and negative relative accommodation increased. So slowly after tapering this to, again, home atropine eye drops, then we started the patient on bifocal glasses simultaneously as we started on cycloplegics. Occlusion therapy was given because it was a unilateral esotropia. And we also gave flippers after tapering. So the esotropia persisted, and then we had to do surgery for the patient in order to conclude.
Dr. Sumita.
Yeah. So hyperopic correction was given in 2 patients, office-based exercise and orthoptics in 4 patients. Cycloplegic eye drops was given in 24 patients, but you can see that 6 patients had persistent esotropia without resolution. So on the whole, 16 had persistent esotropia, out of which 3 underwent surgery and the rest are on follow-up.
Just conclude.
Okay, ma'am. So this is the treatment protocol that we are giving. So follow them up every 2 weekly, taper the treatment accordingly, and start them on home-based exercises. If there is resolution, good. If there is no resolution, then you have to operate these patients for squint surgery. And we also defined these 3 terms: resolution, relapse, as well as recurrence. So resolution will be, if there is no resolution, if there is resolution of everything after 4 weeks. Relapse if, the patient had recurrence of symptoms before the treatment is tapered, and recurrence if the patient had relapse of symptoms after the treatment was tapered. So what we already know is that, this is the last slide, ma'am.
Okay.
What we already know is that accommodative spasm is the most common entity of spasm of near reflex, and it presents with sudden esotropia like acute comitant esotropia. But ours is the largest case series in the post-COVID era, and treatment protocol was also defined, and we also defined resolution, recurrence, and relapse. So a thorough clinical evaluation can therefore help clinch the diagnosis and avoid unnecessary neuroimaging in these patients. Thank you. Sorry,
yeah, thank you, Dr. Sumita. I guess that's a very key topic, especially we see a lot of spasm these days,
Yes.
where the kids have increased
Yes.
the near work and a digital screen time. So I guess I'll move on to the last talk because we have the speakers